I'm going to talk about how Planned Parenthood health centers across the United States have provided IUD services during the pandemic. I'll talk about how telehealth for IUD has been a key part of Planned Parenthood's COVID response, and I'll give a case study from New York City, the epicenter of the pandemic. Next slide, please. ACOG affirms that contraception services are an essential component of comprehensive health care. ACOG also advises that during COVID, LARC removals should be postponed if possible. While we agree, Planned Parenthood also adheres to the principle that requested IUD removals should be provided when possible. At least one of our health centers have created explicit guidance for staff. Previous slide, please. Thank you. At least one of our health centers have created explicit guidance for staff that refusing to remove an IUD, even during COVID, is coercive. However, due to regional variations in COVID incidence, PPE availability, and health system burdens, Planned Parenthood health centers across the country have taken different approaches to IUD service provision during the pandemic. Some health centers have never deviated much from business as usual. These facilities tend to be in regions that did not face critical PPE shortages, and they were working with supportive local and state governments and departments of health that stood behind the idea that contraception is an essential service in a pandemic. Other Planned Parenthood health centers, including a mix of those in supportive and unsupportive states, have responded to PPE shortages and the need to limit traffic in the health center by triaging patients to telehealth whenever appropriate and limiting in-person visits to urgent needs, including IUD removal when there was no acceptable alternative. At those times, these facilities counseled patients about bridging methods when the reason for removal was an expired IUD. Bridging methods are contraceptive methods that can be self-administered, such as pill, patch, and ring, until a patient can come in for new LARC placement. Counseling about use of bridging methods has been a key element of COVID response for centers in some of the hardest hit regions. Despite the regional differences in approach, Planned Parenthood health centers have continued to meet patients' needs for removal when delay in care was unacceptable. And across the country, affiliates are leaning more into virtual care delivery, either on its own or in combination with in-person care, including for IUDs. Next slide, please. When telehealth is used for part of a visit, such as screening, counseling, and consent, and the remainder is provided in person, such as IUD removal, we're calling that a hybrid model. We're finding the hybrid model particularly appropriate for IUD care during the pandemic, and we anticipate that patients will continue to want this approach to care even after the pandemic ends. Pre-COVID research into telehealth showed that Planned Parenthood patients appreciated the convenience of accessing care from home. This was true whether they were urban residents living near health centers or resided in rural communities miles from care. Although the hybrid model of IUD care has not been researched to our knowledge, we anticipate that patients will in general appreciate spending less time at the health center. We plan to study patient experience data related to telehealth to learn more about patient preferences in this regard. Next slide, please. In their COVID-specific guidelines, ACOG advises U.S. healthcare providers to postpone routine LARC removals if possible and counsel LARC users on the effectiveness of extended use beyond the label duration. In order to support Planned Parenthood health centers in following this recommendation, PPFA, the national organization, created a number of resources for affiliates around the country. The tools are designed to help health center staff identify opportunities to minimize face-to-face patient encounters and the time each patient spends at the health center. On the left of this slide is a screenshot of the workflow for patients requesting removal of a LARC method. The tool can be modified depending on whether the health center is triaging all patients to telehealth and bridging methods or continuing to provide in-person care alongside telehealth. For patients requesting LARC removal or replacement, this tool guides health center staff through an assessment of the patient's reasons for removal, discussion of care management options, and ultimately triaging the appointment to telehealth, in-person care, or a hybrid model. The tool is supported by scripts to help health center staff navigate complicated discussions, such as shared decision-making related to removal versus deferral of removal for expired IUDs. On the right of this slide is an example of a script for decision-making related to an expired levonorgestrel 52 milligram IUD. The scripts also include general talking points on use of methods beyond package labeling, including prompts to inform patients that there may be a discrepancy between what the label says and what newer research tells us, and that the care we practice is based on the latest evidence. Next, please. In the last 2 months, Planned Parenthood has expanded into the telehealth space at a pace unimaginable before the pandemic. Telehealth has enormous potential. Nevertheless, we should remain attentive to the ways in which this method of service delivery may not work for all patients in all communities. In general, participating in a telehealth visit requires access to Wi-Fi, privacy, and technology. For non-English speakers, it also requires translation services and written materials in your primary language. Many of our patients are from marginalized communities that face obstacles to accessing healthcare, and these may be exacerbated when care is delivered virtually. Some of our patients do not have Wi-Fi or privacy in their home. Some patients are experiencing increased levels of IPV under stay-at-home orders. For these patients, an in-person visit may be preferred, even safer. In navigating decisions about in-person visits for IUD removal during COVID, we've had to face what can sometimes feel like a tension between protecting the safety of staff and other patients from COVID on the one hand, and a patient's need for reproductive autonomy and control on the other. Fortunately, from a coronavirus transmission perspective, IUD placement and removal are low-risk, non-aerosol generating procedures. And in fact, unpublished data from New York, sent by the governor's office to New York healthcare providers, showed that the incidence of coronavirus infection was lower in healthcare providers than in the general public, probably due to our use of PPE and other protective measures. Next slide, please. Overall, visits for contraception at Planned Parenthood's health centers across the US decreased as people chose to stay home and defer preventive services during the pandemic. The greatest drop in the contraception category was visits for LARC initiation. I don't have data for LARC removals. IUD placements decreased by 37% from March to April, compared with a 15% decrease in cycles of oral contraceptive pills, which can be dispensed by telehealth. By contrast, visits for medication abortion, which can also be provided in part by telehealth, increased by 21% in that time period. Next slide, please. Now let's take a look at how Planned Parenthood of Greater New York approached IUD care during COVID. Planned Parenthood of Greater New York, or PPGNY, includes New York City, the US epicenter of the COVID pandemic. About 10, 11 weeks ago, when COVID first hit New York with full force, the New York State Department of Health issued guidance encouraging all healthcare providers to use telehealth when possible and appropriate. At that time, the New York Planned Parenthood affiliate took a triage approach to all birth control method issues, including requests for IUD removal. This took the form of clinicians having in-depth conversations by phone with patients to assess symptoms and plan care, whether in person or use of the bridging method. In general, patients were steered to telehealth at that time, and to be frank, during those first weeks, few patients wanted to be seen in person. Nevertheless, the affiliate did remain open for anyone who needed in-person care. In recent weeks, with the drop in new hospitalized cases in New York and more availability of PPE, Planned Parenthood of Greater New York has changed its approach to care and its messaging to staff and patients. The affiliate is offering everyone a visit by telehealth and in person. The decision is made by the patient, and the health centers stand ready to see whomever wants to come in person. All initial calls for IUD removals include assessing the reasons for desired removal. If the reason is related to concerns about expiration, patients are informed of options for extended use. If for other reasons, staff and patients discuss removal versus delaying care using a model of patient-directed shared decision-making. The center directors and staff have taken a thoughtful approach to equity issues implicit in promoting telehealth as a primary modality, and the need to ensure against the potential to make racially biased or paternalistic decisions. Their DEI, diversity, equity, and inclusion team has been central to the formation of this approach. Challenges remain, including the ongoing need to protect staff and other patients from potential COVID infection and the need to support reproductive autonomy. This affiliate has found that the key is trusting to patients to decide where to receive care for essential services. The role of the center staff is to ensure patients understand the associated risks, either with a decision to come in person or to receive care by telehealth, which for an IUD may mean delaying removal.